Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's VABYSMO-HCP.com.
Welcome to New Retina Radio. I'm your host, Dr. John Kitchens, and today we're talking about a dual pathway inhibiting therapy for the treatment of patients with diabetic macular edema. This special episode of New Retina Radio is supported by Genentech, which is responsible for its content. We have been compensated by Genentech to serve as speakers for this program. This program is intended to provide general information about Vabysmo, faricimab, and not medical advice for any particular patient. Any adverse events included in this discussion today have already been reported to Genentech Drug Safety, and no action is required by any listener. In this episode, we're going to cover several different topics, including the management of patients with DME, the clinical efficacy and safety data in the Yosemite and Rhine trials, and real-world clinical experience utilizing Vabysmo in patients with DME. Vabysmo, or faricimab, SVOA, is a vascular endothelial growth factor, or VEGF inhibitor, and angiopoietin-2, or Ang2 inhibitor, indicated for the treatment of patients with neovascular or wet age-related macular degeneration, or diabetic macular edema, DME, and macular edema following retinal vein occlusion, otherwise known as RVO. Vabysmo is contraindicated in patients with ocular or periocular infection, in patients with active intraocular inflammation, and in patients with known hypersensitivity to faricimab or any of the excipients in Vabysmo. Hypersensitivity reactions may manifest as rash, pruritus, urticaria, erythema, or severe intraocular inflammation. My guest is Dr. Maria Berrocal. Maria is from Puerto Rico, and I'd like to welcome you to the podcast, Maria. Welcome, and tell us a little bit about your practice.
Yes, thank you, John. I practice in Puerto Rico, and Puerto Rico has a very high incidence of diabetes, so I have many patients with proliferative diabetic retinopathy and diabetic macular edema that need treatment. And many of these patients, I am in an island. I have patients from the island, from adjoining islands. So coming in for visits can sometimes be a challenge.
So you mentioned those challenges, and certainly they're not unique to Puerto Rico, but probably more emphasized in Puerto Rico. Tell us about the access to care and how it differs in Puerto Rico as far as access, treatment burden, and other things for our patients there.
Well, Puerto Rico, we have a population that everybody is insured, but over 50% of patients are Medicaid type patients, which means that oftentimes they need pre-approval for things. They cannot get into appointments. We have a very large elderly population, and with a significant number of diabetics who don't have the most optimal of care. So diabetic macular edema is one of the diseases that I see the most.
And certainly, when you see those patients that have kind of the worst of the worst, diabetic macular edema, do you change your treatment goals for those patients, Maria? Or do you think that they can actually achieve the same outcomes as we see in those patients that are more moderate as far as their DME?
Well, when somebody comes in that has had diabetic macular edema for a very long time without a response, we know that damages the photoreceptors. So what I try to do is to provide treatments that may provide fast drying, because the longer we keep them with edema, the worse the final outcomes will be.
And Maria, I'll tell you, I learned something very unique from you, and that is OCT characteristics that might indicate that the diabetic macular edema has more of an inflammatory role. Do you care to elaborate on that?
Yes, we know when I look at an OCT, I can tell if this is very mild edema or if there's a very significant inflammatory component. And the inflammatory biomarkers are subretinal fluid, intraretinal cystic space, and highly reflective foci. And when I see these things, an eye that almost looks like it has diabetic macular edema, I know that inflammation is a key component. In my opinion, we should use the best drug for all patients because we know that the longer we keep an eye with edema, the more damage to the photoreceptors we're going to see, and we won't be able to achieve as good visual acuity as we would.
So, Maria, we have a variety of different classes of drugs to treat diabetic macular edema. We have anti-VEGF therapy, we have steroids, we even still have laser. Where does this fall in class? Do we use anti-VEGFs first all the time? Are there cases where we might use intravitreal steroids? How do you tier your therapy choices?
Well, I used to use a lot of intravitreal steroids whenever patients were unresponsive for anti-VEGF. But since now we have a dual therapy drug that, in my opinion, actually tackles inflammation really well and is very good for cases in which we see all the inflammatory biomarkers. I have been using steroids much less, and I usually start these patients just with the dual pathway drug.
We have so many great clinical studies that have come out in the last few years, new drugs approved and whatnot. I find it very difficult to duplicate or replicate clinical trials in my treatment patterns. Any thoughts on how we can best achieve those clinical trial-like results in our practices?
Well, the problem with clinical trials is that we have very compliant patients that come in all the time at fixed schedules and never miss any appointments. And this is not real life. In real life, patients lose insurance. In real life, patients get sick and get hospitalized. In real life, patients move places and they can't get in for an appointment. So in reality, the notion of the results we get with clinical trials, having patients come in monthly, is totally unrealistic. Patients cannot be taking a day of work every month just for the eyes when they have all these other appointments and they have all these other commitments. So a drug that provides more lasting effects and lasts longer, for me, has benefit.
Maria, I'd really love to talk about the Yosemite and Rhine studies. Now, these studies were the pivotal phase 3 studies that led to the FDA approval of faricimab, known as Vabysmo, for the treatment of diabetic macular edema. The Yosemite and Rhine trials were the largest 2-year phase 3 studies in DME, designed to assess the efficacy and safety of Vabysmo versus aflibercept in treatment-naive and previously treated patients. There were 3 study arms, 2 Vabysmo arms with 632 patients each, and an aflibercept control arm with 627 patients. In the aflibercept arm, we followed its 2 milligram labeled dosing with a loading dose of 5 initial monthly doses, followed by a fixed dose of Q8 weeks. For Vabysmo, the loading dose phase was 4 initial monthly injections, followed by either a fixed dose Q8 week or variable dosing group that was dosed every 4, 8, 12, or 16 weeks. In this variable dosing group, dose frequency depended on disease activity and could be increased or decreased by 4-week intervals. Based on this trial design, Vabysmo was FDA approved for multiple regimens ranging from Q4 weeks to Q16 weeks after completing 4 monthly doses. Vabysmo delivered first-line efficacy by meeting its primary endpoint of non-inferiority versus aflibercept 2 milligram Q8 weeks, which was assessed as the mean change in best-corrected visual acuity at year 1 at weeks 48, 52, and 56. In the variable dose Vabysmo arm, patients gained an average of 11.2 letters versus 10.5 letters in the aflibercept arm at year 1. Vision gains were maintained through year 2 versus aflibercept 2 milligram regimen, with an average of 10.8 letters gained in the variable dose Vabysmo group versus 10.3 letters in the aflibercept group. Anatomical outcomes were also assessed in the clinical trials as secondary outcomes. Patients on Vabysmo achieved greater central subfield thickness reductions versus aflibercept 2 milligram, with a 174.5 micron decrease in CST for the Vabysmo variable dosing arm compared with a decrease of 151.7 microns for aflibercept at week 16 of the matched dose phase. These results were maintained at year 1, where the variable dose Vabysmo group had a decrease of 195.2 microns versus 167.8 microns in the aflibercept 2 milligram group. CST improvements were maintained at year 2. Greater retinal drying was also achieved in the variable dose Vabysmo group compared to aflibercept 2 milligram during the matched dose phase, with 21% of patients achieving rapid and sustained resolution of intraretinal fluid at week 16 versus 13% in the aflibercept group. These results continued at year 1, with 41% of patients in the variable dose Vabysmo group achieving intraretinal fluid resolution compared to 26% of patients in the aflibercept arm. Now, it's important to keep in mind the following for these two pre-specified secondary endpoints. Clinical significance of this outcome has not been established, and conclusions regarding treatment effect cannot be drawn. For both endpoints, p-values for superiority testing are nominal and not adjusted for multiplicity. Therefore, no formal statistical conclusion should be made based on the p-values. For retinal drying, specifically, the studies defined this pre-specified secondary endpoint as an absence of intraretinal fluid. They were matched as far as their design is concerned. They had patients that were treated with the faricimab every 8 weeks after a loading dose. That was compared to aflibercept 2 milligrams, but the unique thing was they had a variable dosing group. That's very unique. Can you care to tell us about that variable dosing group and why it's so unique in this study?
What I think is unique about these trials is that it really replicates what we do in real life. All the other trials would be fixed dose every 8 weeks, but we know that patients that can be extended, we extend the treatment interval, and then if they reaccumulate fluid, we cut back. So it really replicates what we normally do in clinical practice. And that is hugely advantageous because we can see what percentage of patients we can actually extend and how far.
Yeah, I agree. I think that this is, at least how I treat patients, the most true to life treatment group in this clinical study, and maybe the most true to life treatment group that I've seen in any clinical trial. A real true treat and extend, but also a treat and contract, which I think really taught us about sustainability of our drying effects. So you were able to treat those patients, and if they were doing well, extend them out by a month in between each injection. But if they weren't doing as well, you were able to dial them back. Maria, what did we see amongst those 3 treatment groups?
Well, what we saw, and we saw that at year 1 and at year 2, that we had over 70% of patients that could be extended to receive an injection every 3 to 4 months. And we had never seen this before. And I think this is really dramatic, and it has really changed, in my mind, the paradigm of how I treat diabetic patients.
Yeah, it certainly did start to establish that. And how has that changed your clinical practice? Are you now starting to extend patients out further?
Yes, I extend patients. I have extended many patients to 3, 4 months with this medication.
And one of the unique things that I think we see in this study is a very rapid drying effect. And you talked about this earlier, just how quickly agents are able to get patients dry. What did we see and learn about the time to drying for these people?
One of the things that I think we don't talk enough about is how detrimental it is to have a patient stay with edema for a very long period of time, because those are the patients that we finally dry them out, but the visual acuity doesn't improve. And it's just because of the damage that all the fluid caused to those photoreceptors and to that retina. You keep injecting and they go, but I'm seeing the same, the OCT looks the same, I still have edema. And those are the patients that don't come back often just because they get frustrated with not seeing quick results. I think that is something that is not underscored enough.
And lastly, let's talk about safety in the Yosemite and Rhine study. Vabysmo demonstrated safety similar to aflibercept over 2 years. Intravitreal injections that inhibit VEGF, including Vabysmo, have been associated with endophthalmitis and retinal detachment, increases in IOP, and arterial thromboembolic events. The most common adverse reactions reported in patients receiving Vabysmo were cataract, occurring in 15%, and conjunctival hemorrhage, occurring in 8% of patients. No cases of retinal vasculitis with or without occlusion were reported during the trials. Only a small number of retinal occlusive events were reported, and exposure-adjusted incidence rate of retinal occlusive events were low across treatment arms.
So we did not see any safety concerns.
And back to your original point about fewer treatments, greater intervals in between treatments, the biggest key for me when I'm talking to patients about safety is saying, hey, fewer injections equals less chance for having something bad happen. Lowers the risk. You want to lower the risk of endophthalmitis, do fewer injections. That will reduce your chances of this very rare but real, possibility of an infection occurring. And if we're able to achieve that, that reduces our risk of those very severe complications.
I agree completely.
I think that's a great discussion of the Yosemite and Rhine studies. Once again, the phase 3 FDA kind of sentinel trials for the approval of faricimab for the treatment of diabetic macular edema. We're going to take a little break here. And when we come back, we're going to talk to Maria about some real world DME patient cases.
Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's VABYSMO-HCP.com.
Welcome back to From Trials to the Clinic, treatment of patients with DME with a dual pathway inhibiting therapy. Once again, I'm joined by Dr. Maria Berrocal, and we're going to talk about some patient cases. Maria, you have a great patient case. It looks like a tough case. Why don't you tell us about your gentleman that had diabetic macular edema?
Yeah, this is a 77-year-old male who had a baseline best-corrected visual acuity of 2200 and had been treated, the left eye, with 11 prior doses of bevacizumab monthly and then 5 monthly doses of Eylea. And when at that point, the patient has had a visual acuity of 2200 and a CST of 660. And if you look at the OCT, you see all of the biomarkers of inflammation. A significant subretinal fluid, you see edema, cystic spaces, hyperreflective foci, everything. So I started treating the patient at 4-week intervals.
And
With
Maria, I got to jump in
Vabysmo.
here for a second and just say, if I know people can't see this, that's a lot of subretinal fluid. You mentioned that as one of those inflammatory markers. This patient has at least 400 or 500 microns purely of subretinal fluid, along with, like you said, hyperreflective foci and intraretinal edema. This is a tough case. Go ahead. Sorry for interrupting.
Now, this is a very difficult case and one that had no response whatsoever to the 2 previous anti-VEGFs. And I was, skeptical whether I would get a response. But the CST kept improving at every single injection point from 660 to 630 to 480 to 300. And I was able to extend this patient at the 7th injection to every 12 weeks with a CST of 219, something that totally surprised me.
Yeah, I would tell you from almost 700 microns of central subfield thickness to under 300 microns of central subfield thickness. And it didn't happen overnight, but I'm actually surprised it happened at all. This would be a patient that, in my mind, I would have been thinking, after all of those previous injections, oh gosh, we're going to have to add a steroid. Is this going to be somebody that's just going to have persistent edema? Quite surprising at how nicely this patient improved. And when you look at it, it really falls in line with what we saw as far as that drying effect in Yosemite and Rhine, where those patients actually did get dry by month 8 and month 9. Even the tough patients seem to have a good response.
Yeah, this patient, this all happened within 7 months.
Wow, that's amazing. And did the patient notice an improvement in visual acuity?
Well, the visual acuity remained at 2200, but again, this patient had this severe edema for several years. So I think just having no fluid and no subretinal fluid is very advantageous.
Yeah, I can tell you that this is one of the toughest looking cases as far as diabetic macular edema is concerned that I've seen. And the fact that you could actually get this dry, this would be a patient I would imagine at some point, if that edema did not improve, that this patient would end up with count fingers vision. And we would just write this eye off and just say, this is an eye that we're lucky to have any vision in. And yet you've been able to dry out this retina, keep this patient stable, maybe give them some potential for future, visual acuity improvements, but really remarkable improvement there.
Yeah, and I was able to extend that at the last injection. I had extended this patient to Q 12 weeks, and no adverse events were noted on this patient.
Maria, I'd love to show you my case here. This is a 51-year-old diabetic gentleman who came in working age, and he had about 3 or 4 months of decreased vision in both eyes, to the point now where his family didn't feel safe with him driving. And the problem is that he's a working individual. And when he presented, his visual acuity was 2400, and he had massive intraretinal edema in both eyes. Maybe not quite as bad as your patient's left eye, but in this patient, he had well over 600 microns. He had the subretinal fluid you described, lots of intraretinal edema, severe non-proliferative retinopathy with cotton wool spots and whatnot. And fortunately, we were able to get him started on faricimab initially. And I thought to myself, I've seen the drying data from Yosemite and Ryan and the rapidity at which faricimab gets patients dry in those studies. And I'm going to put it to the test. And I'm going to see in this patient that had bilateral significant edema and honestly was freaking out about his inability to work. I'm going to see if it can get this patient dry after the initial 3, 4, 5 injections. And I treated him with a couple of faricimab injections. And after the first 2 injections, he had significant improvement. And in fact, his edema in his right eye was 311 microns. The left eye was under 300 microns. His vision improved to 20/70 and 20/50. And for me, there was a bit of a wow effect from this. What do you think, looking at his images where we can see his pre-injection images with the extensive edema, subretinal fluid, and then his post-2 faricimab injection images?
Well, John, I think this case really underscores the importance of drying patients quickly. And we can see here how, faricimab actually causes drying, but not only the drying effect, but also the improvement of vision, something that, we did not see in my patient, which had been with edema for years. So in my mind, I should offer the treatment to my diabetic patients that are severe like this, that will offer the drying effect.
And with an additional injection, he got a little bit drier, and I was actually able to start to extend him earlier than I expected. He was able to return to work and driving, which was huge. And I'll tell you, he is the most grateful patient. I think in so many instances when we have new therapies, we reserve those new therapies for our toughest to treat patients, the ones that have had numerous injections before we actually, and those are the ones that we test the new agent on. And that may not be as fair, and it certainly might not allow you to see just how impressive some of these newer agents can be in treatment naive patients. And this really is what flipped the switch for me to say, gosh, you know what? Can I achieve this if this is my first line therapy for my diabetic patients? And so this was the case that really kind of made me say, hey, if I can get this for patients, I'm going to make every effort to. And like with your case, this patient had no ocular adverse events associated with their injection, has done well, and is very much in line with what we saw in Yosemite and Rhine as far as the safety concerns.
Yes, John, I think we do a disservice in not offering our patients the best treatment we can.
So this is obviously the results for this specific patient, but it certainly gets me enthusiastic about using this treatment in other treatment naive patients as well. Well, this was certainly amazingly informative. Maria, thank you so much for joining us on this episode of New Retina Radio, From Trials to the Clinic, Treatment of Patients with DME, Utilizing a Dual Pathway Inhibitory Therapy. Be sure to go back and listen to the first episode in this podcast, where we learn about other unique aspects of treating patients with exudative age-related macular degeneration with faricimab.
Important safety information. Indications. Vabysmo, faricimab SVOA, is a vascular endothelial growth factor VEGF inhibitor and angiopoietin 2 Ang2 inhibitor indicated for the treatment of patients with neovascular wet age-related macular degeneration NAMD, diabetic macular edema DME, and macular edema following retinal vein occlusion RVO. Important safety information. Contraindications. Vabysmo is contraindicated in patients with ocular or periocular infection, in patients with active intraocular inflammation, and in patients with known hypersensitivity to faricimab or any of the excipients in Vabysmo. Hypersensitivity reactions may manifest as rash, pruritus, urticaria, erythema, or severe intraocular inflammation. Warnings and precautions. Endophthalmitis and retinal detachments. Intravitreal injections have been associated with endophthalmitis and retinal detachments. Proper aseptic injection techniques must always be used when administering Vabysmo. Patients should be instructed to report any symptoms suggestive of endophthalmitis or retinal detachment without delay, to permit prompt and appropriate management. Increase in intraocular pressure. Transient increases in intraocular pressure, IOP, have been seen within 60 minutes of intravitreal injection, including with Vabysmo. IOP and the perfusion of the optic nerve head should be monitored and managed appropriately. Thromboembolic events. Although there was a low rate of arterial thromboembolic events, ATEs, observed in the Vabysmo clinical trials, there is a potential risk of ATEs following intravitreal use of VEGF inhibitors. ATEs are defined as non-fatal stroke, non-fatal myocardial infarction, or vascular death, including deaths of unknown cause. The incidence of reported ATEs in the NAMD studies during the first year was 1%, 7 out of 664, in patients treated with Vabysmo, compared with 1%, 6 out of 662, in patients treated with aflibercept. The incidence of reported ATEs in the DME studies from baseline to week 100 was 5%, 64 out of 1,262 in patients treated with Vabysmo, compared with 5%, 32 out of 625 in patients treated with aflibercept. The incidence of reported ATEs in the RVO studies during the first 6 months was 1.1%, 7 out of 641 in patients treated with Vabysmo, compared with 1.4%, 9 out of 635 in patients treated with aflibercept. Retinal vasculitis and/or retinal vascular occlusion, typically in the presence of intraocular inflammation, have been reported with the use of Vabysmo. Healthcare providers should discontinue treatment with Vabysmo in patients who develop these events. Patients should be instructed to report any change in vision without delay. Adverse reactions. The most common adverse reactions, greater than or equal to 5%, reported in patients receiving Vabysmo were cataract 15% and conjunctival hemorrhage 8%. Pregnancy, lactation, females and males of reproductive potential. Based on the mechanism of action of VEGF and Ang2 inhibitors, there is a potential risk to female reproductive capacity and to embryo-fetal development. Vabysmo should not be used during pregnancy unless the potential benefit to the patient outweighs the potential risk to the fetus. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for Vabysmo and any potential adverse effects on the breastfed child from Vabysmo. Females of reproductive potential are advised to use effective contraception prior to the initial dose, during treatment, and for at least 3 months following the last dose of Vabysmo. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555. Please see additional important safety information in the full Vabysmo prescribing information.